Good afternoon, ladies and gentlemen. Chairman, let me first express my appreciation to the organizer to the ACRE for this kind invitation. Well, we are going to speak about our experience in the treatment of brain metastasis using the CyberKnife, frameless robotic radiosurgery, and together we'll try also to answer this question whether there is any benefit or even a limitation in using frameless radiosurgery to treat those lesions. This is our experience. We started in July 2007, and since then we treated 431 patients with 848 lesions. Most of them were non-small cell lung cancer and breast cancer. Maybe you know that the CyberKnife can use 3 different algorithms to generate the treatment planning for any brain lesions. One is a typical isocentric technique, so the linac moves around the patient head, generating arcs, non-covalent arcs, exactly as the gantry-based system. So this is generate isocenters, meaning spheres of radiations. This can be suitable for treating spheric lesions, like usually are metastasis. But we quickly moved to non-isocentric technique, which means that you can use beams or radiations, single beams, so you can paint the dose around the lesions. Most importantly, you can, of course, use the frameless technology to treat lesions in multiple sessions, as we have seen in the previous presentation. But in our series, we treat most of our patients in single fraction, so we try to be ablative, as much ablative as possible. This is the approach that we used in our series, but not in all patients. So we have 10% of the patients that underwent multiple session radiosurgery, and of course is the most interesting part of our series, because of course it's something that you can use only with frameless technology. This is the dose distribution that usually you can achieve using this technology. You can see that the distribution of isodose around the lesions are very, very interesting. And you can treat lesions like that, internal capsule tumor, breast cancer with very good results without any deficit. These are another lesions very close to the motor area, and again, the results are very good. Of course, they are small lesions. But of course, if you look to the conformality, which means the distribution of the dose around the lesions, we can see that the best results can be achieved for lesions like that one, very complexly shaped lesions. So one of the main questions we always encounter in my practice, and when I discuss with other people involved in the issue of radiosurgery, is can we rely on this technology? I mean, can we rely on frameless technology? It's something that is strongly debated by, especially by neurosurgeons. They are used to use the frame in their practice, in their daily practice. So this is the summary of end-to-end control made by physicists along 5 years. And we can see here that for both the fixed collimators, then for the dynamic collimator, which is called iris, we have an error which is within 0.6 millimeters. That is far more than acceptable in our daily practice. Most importantly, after hundreds of patients treated, I strongly believe, and my colleague with me, that we don't need any expansion of the target volume to get planning treatment volume or clinical treatment volume like that. We just treat the GTV. This is the results of our World Series. We can see here the median number of lesions is 2. The median dose in single fraction is 20 gray, which is the dose to whom we aim in our treatments. The median dose in fractionated treatment in 27.5 in 5 fractions, ranging 24 to 30. Median isodose is 75% isodose. So this is the median survival of the whole group. You can see here it's a bit dismal, disappointing, I would say. It's not different from other series, 11 months. But of course, there are patients that may do much better. RPA class 1, of course, have a better survival, ranging about 17 to 19 months. Of course, patients with a controlled systemic disease behave much better, and this means, and we will discuss later, that the systemic disease is the major predictor of the survival of patients with brain metastasis, at least in our series. Multiple metastasis is a very modern issue. There's a couple of papers that have been published very recently. We can see here that this is the first one published on the Red Journal from the Stanford group. You know, this is the group where the CyberNet was developed. And we can see here that they are suggesting to repeat radiosurgery after the first course for the first metastasis to defer whole brain radiotherapy. At the same time, there is the series, there are a lot of papers published by Yamamoto suggesting the treatment of many lesions. Patients with more than 10 lesions can be treated with radiosurgery. These are another interesting lesions. And of course, using frameless technology, I wonder whether there is an advantage in treating this specific category of patients. And I say, okay, using frameless, we have time for planning, which for us is okay. We have time to deliver to treat the patient, because treating many lesions in the same patient requires time. And also, we usually treat multiple lesions in multiple days, just to allow a certain degree of recovery of the intervening brain between the different metastases. And of course, we can use multi-session for specific sites, like brainstem metastasis, and we will discuss later at this point. A couple of examples. You can see a patient with multiple lesions. 12 months later, the disease is under control. Very good control. This is a patient with big lesions, and also in this case, you can see results are more than acceptable. A few months later, there's another patient with again multiple large lesions, all in the posterior fossa. And again, the disease is under control. We can see here that we have some kind of leptomeningeal carcinomatosis. So this means that the disease can be controlled, but until a certain level. Well, in our series, the presence of multiple lesions, meaning 2 to 4 lesions, is not a predictor of a shorter survival. This is the median local control, which is very good, 38 months. And we can see here that after 1 year, we have 90% local control, almost 90, and after 2 years we have almost 70% local control. This means that we can control with radiosurgery the disease, at least at local level. Nevertheless, we can see that the longer the patient is going to survive, the higher is the probability to see this kind of imaging, which means radiation therapy-induced side effects, or even the widespread diffusion of the disease. And we can see here this very unusual case with both the trigeminal nerves are involved into the disease. It's very painful and very severe disease diffusion in this patient that has survived 8 years after initial diagnosis. Of course, different discussion can be done for radio-resistant isotypes, and we can see this is a small series of patients with melanoma metastasis. They are doing much worse than other patients in the general population. Survival is much shorter, and they behave as patients with uncontrolled systemic disease independently on their status. Furthermore, this complication rate, we can see here, non-melanoma metastasis has 17% of symptomatic edema, but melanoma patient has about 40% complication rate because 23% has bled after treatment. Bleeding is one major complication. So going to the main point of this presentation, which is the use of multi-session radiosurgery for patients with brain metastasis. Of course, this is an option that can be used in several distinct situations, such as the presence of large or very large tumors, to treat the tumor bed after surgery, to treat brainstem metastases, to treat complex skull-based lesions, to retreat patients, and also a simultaneous integrated use throughout the whole brain radiotherapy treatment for at least for radioresistant metastases. So I'll show you a few cases like this one. Okay, this is a very complicated patient to treat by radiosurgery because you need a dose, a very low dose, but using multisation or hypofractionated as you want to call this kind of treatment, sometimes you can achieve a very nice results like this one. The disease can be controlled in the long term. But still, it still remains important that in our experience, the presence of large lesions is one main limitation and is predictive of shorter survival as compared to patients with a shorter, with a smaller lesion. So the number of lesion is not so important, but the size of the lesion is important, at least in my experience. Another opportunity is the treatment of tumor bed, and so this the multi-session radiosurgery is very suitable for this large tumor bed that can be. It's very difficult to treat in single fraction, so you can use multi-session. It's very useful. You can achieve very good dose distribution. Sometimes you can treat the tumor bed with different doses. It's something like in this case. It's a very flexible. CyberKnife is very flexible. You can have different targets with different doses of radiations. Brainstem metastases, of course, they are very difficult. Treating this lesion, you have to use very low doses unless you want to have a radionecrosis into the brainstem. But we had a very good experience with the fractionated radiosurgery. We use 5 fractions, 25 grays in 5 fractions. And we often see results like this. The disease is under control several months later without any complication for the patient. Well, complex skull-based lesions, we can treat tumors like that with fractionated frameless technology, skull-based tumors. There's another skull-based tumors. You can see the PET scan before and after the treatment. Pre-treatment is something that I want to show you because, in my opinion, it's very interesting because, okay, we often treat lesions like that. And, I mean, 12, 13 months later, we see imaging like this one. We can see hyper-intense imaging here. We can see here that this lesion is contrast-enhancing. Okay, so what is this? Is that a radionecrosis or is it recurrent tumors? Nobody knows. Now we have neuroimaging showing us that it's possible to say that this is radionecrosis, but I'm sure that this is not radionecrosis, this is not recurrence. In most of the instances, this is both of them. So you will find radionecrosis together with tumor cells surviving. So what to do in this case? We can retreat single fraction radiosurgery, but sometimes this is what we find. So symptomatic edema, complication radionecrosis, and especially epilepsy that is very difficult to control with drugs. So what is possible? This is my personal feeling. If I treated one lesion in one single fraction, there's no reason to retreat in single fraction. So I try to treat surviving cells that may be different from the original cells because they are epoxic. They survived high doses of radiations. So probably they changed their biology, they changed the alpha-beta ratio, and I try to treat them in multiple fractions. And I think that this is a good approach, at least to avoid complication from repeated radiosurgery. In few cases, we did like this. We try to treat the whole brain. This is a melanoma metastasis patients. We treated the whole brain with 20 grays in 5 fractions with whole brain radiotherapy, and together we delivered a simultaneous integrated boost of other 20 grays. So we reached the 40 grays on these lesions, and in this specific case, we achieved this very nice result. Something we can do with this technology is the opportunity to integrate functional neuroimaging. This is a three-dimensional rendering. It's something that I worked on in the past. It's a three-dimensional rendering of an MRI. We can see here with integration of functional imaging. We can see it's a functional area of the foot, the functional area of the hand, functional area of the face. This is a corticospinal tract. This is the tumor. And this is the bidimensional MRI. We can see here this corticospinal tract on this side, this corticospinal tract on the other side. This functional area of the foot, functional area of the hand. This is something really new that we are trying, is navigated transcranial magnetic stimulation. So you can see here, we can stimulate the patient brain transcranially with a navigated system, and we generate these spots. You can see the response are recorded on the head, on the hand, on the leg, on the face, and so on. And we can report, we can map the motor area, and we can report these spots on the cortical surface of the patients. We can combine this with corticospinal tractography. Here you can see the corticospinal tract, and we can generate our treatments. This is there is a superimposition of the tumor together with the functional area. We can change our target volume, and of course the dose distribution can be more satisfactory. So in conclusion, CyberKnife appears to be an effective strategy to treat metastatic brain disease. Local control, in my opinion, is very satisfactory, at least in the midterm. At midterm, of course, long-term patients, long-term surviving patient will have problems from the metastatic disease anyway, but survival is still dismal. Best results, of course, are in RPA class 1 patients or patients with small lesion or in the controlled extracranial disease. Multi-session surgery represents a reasonable option in case of large lesions. Large lesion, okay, that's no problem. In large lesion in patient with multiple metastases and patient at time of retreatment and for tumors who are in the brainstem or close to other critical area. Thank you very much for your attention.
We have time for a few questions. I had a question about the resection cavity dose in multifraction. What BD do you choose for this? You make it in 3 fractions of 7, or what dose do you choose for?
It's a very good question because, of course, there is no evidence that one fractionation is better than another one. The dose fraction ratio remains the main issue of hypofractionation. I call this is the realm of hypofractionation. It's something that nobody knows exactly what is better, because we know almost anything about single fraction and conventional fractionation. So we know very well that something is working with 27, 28, 30 fractions. We know that something works with single fraction, but nobody knows what exactly works in 3, 4, 5 fractions. In general, I think that we can decide, the volume is one main issue, so the bigger is the size of the lesion, the higher is the number of fractions. So we just decide the number of fractions. After that, we try to have a BD evaluation. So I think if I have a large lesion, which is and I decide to treat this lesion in 5 fractions, I try to calculate a BD, a biological equivalent dose, to have 14, 15, 16 grays in single fraction. So I calculate the equivalent dose. So we don't stay below 25 grays in 5 fractions, but we try to get 30 or more grays in 5 fractions. And the same we do in 3 fractions.
Crucial.
Okay. I have a quick question for you. What is your experience with the necrotic metastasis with a lot of edema? Because you show some lesion located superficially with edema and with a cystic or necrotic aspect. I mean, in our institution, we tend to operate this lesion and then do a tumor bed.
Okay. Yes, this is a very interesting question. Thank you. And well, I have a personal view. Of course, patient with a big edema and I should be operated on. I remain a neurosurgeon, but sometimes this is not possible. I mean, some superficial lesions can be operated. Some deep lesions probably are not worth to be being operated on. But in my personal opinion, if you have edema, the edema can increase after treatment if the lesion is not responding to the treatment. But if the lesion is responding to the treatment, is sensitive to radiations, also the edema can be controlled. So the point is the responsiveness of the lesion to the treatment. If you do the right treatment, if the lesion is going to respond, also the edema will be controlled and will decrease. But if the lesion is not going to be controlled, anything is going to be badly.
Thank you.